Let's go over the answers to the warm-up. First question, what clinical features suggest congenital pyloric stenosis? Well, it's usually seen in patients 2 to 6 weeks of age, and it's more common in male infants than in females. The classic presentation is firstborn males. Patients present with non-bilious projectile vomiting, and because of the vomiting, they often have dehydration and possibly some metabolic alkalosis, which is going to be a hypokalemic, hypochloremic metabolic alkalosis if they've been vomiting for at least 5 days. On physical exam, you may feel a palpable olive-like bulge in the upper abdomen, and you may see slow peristaltic waves across the abdomen just before the baby vomits, moving from left to right across the abdomen. Next, what are the features of Plummer-Vinson syndrome? Plummer-Vinson syndrome is a triad of dysphagia from esophageal webs, glossitis, and iron deficiency. And the last one, what is Dressler syndrome? Dressler syndrome is pericarditis that occurs usually 2 to 4 weeks or more after an MI. The patient can present with chest pain, fever, and an increased sed rate. All right, let's move on to the lecture.
Hi. In this lecture, we will move on to the evaluation of diagnostic tests. This is a 5-star topic. This is huge. You're going to have a few questions on sensitivity, specificity, positive and negative predictive value, what these terms mean, and how to calculate them. So you need to be very diagnostic test savvy. You should study this stuff and know it very, very well, and I promise that it's not difficult and it could really pay off for you. The first thing you need to be able to do is construct a 2x2 table that we use to evaluate diagnostic tests. If you can learn how to draw this table and fill in the numbers, that's 90% of the battle. Basically, memorize this table. Look along the y-axis here and see that it's labeled test, which can either be positive or negative. Now look at the x-axis and see that is labeled disease. The patient can either be positive for disease, that is the disease is present, or negative for that disease, the disease is absent. Some students use the mnemonic, disease always comes out on top. A little depressing, but it can help you remember that disease is written along that x-axis. Now, by knowing whether the test was positive or negative and whether the disease was present or absent, we can determine how good that test is. Specifically, how sensitive, how specific, how accurate a positive or negative value for that test actually is. So true positives are people that have a positive test who actually have the disease. That's exactly what you would want. People that test positive and don't have the disease are considered a false positive. But people that have the disease and are testing negative, they're a false negative, and you don't want that either. People that don't have the disease that are testing negative would be a true negative, and again, that's a desirable situation. Okay, let's first talk about sensitivity. How do we determine the sensitivity of the test? Well, the sensitivity is a calculation of all the true positives divided by everyone who actually has the disease. That is, the true positives plus the false negatives. So true positives are in the numerator, and the true positives plus false negatives are in the denominator. This is the proportion of people with the disease who get a positive test result. It's really very simple. So you have a group of 10 people that you know have HIV, and so you do an ELISA test, and the likelihood that the ELISA test will be positive in all 10 people is your sensitivity. If there's 100% sensitivity, then everybody in this group tests positive, and you will not have any false negatives. So sensitivity would be 1. Another way to calculate sensitivity is 1 minus the false negative rate. So in this ELISA example, with no false negatives, you have 1 minus 0 equals 1. Now, when I learned this, I actually learned sensitivity equals PID. Now, PID can mean pelvic inflammatory disease, so it's a very common acronym and used for a disease that causes a lot of pelvic sensitivity. But here it means positive in disease. So sensitivity equals the proportion of disease to people who have a positive test. That is, the proportion that have a positive test in the presence of disease, PID. Okay, now for specificity. Specificity is the proportion of all people without the disease who have a negative test result. Or another way to say that would be all those without the disease who correctly test negative. The true negatives divided by the total without the disease. So this would be the true negatives divided by your true negatives plus false positives. So let's say that you had 10 people without disease A that you tested using the new screening test. Of the 10 tested, 2 tested positive and 8 tested negative. To calculate the specificity of the test, you would put the number of true negatives in the numerator and the total true negatives plus false positives in the denominator. In this case, it would be 8 divided by 10, which equals 0.8 or 80%. Another way to calculate the specificity is 1 minus the false positive rate. The false positive rate is the number of false positives, in this case 2, over the total false positives plus true negatives, in this case 10. So 2 over 10 would be 0.2. So the specificity would be 1 minus 0.2, which is 0.8 or 80%. So again, when I was learning about this in medical school, I learned specificity equals NIH. So the NIH can mean the National Institutes of Health, so again, a common acronym. But here for specificity, it means negative in health. Specificity is the proportion of people who have a negative test result in the presence of health. NIH equals negative in health. Different approaches work for different people. Whatever works for you to understand this, just do it that way. If nothing else, just memorize the equations. You can use A, B, C, and D's to fill in the table. If you know the equations, know your diagram, and know where your true positives, false positives, true negatives, and false negatives fall into that diagram, then that's probably 90% of the battle here. Whichever way you choose to remember this stuff is fine. In fact, on the day of your test, I would recommend that you take a couple of minutes at the very beginning of your first block of questions and draw a little 2x2 table and write down all these equations. This is a great marker board topic. Let's talk about a clinical use for sensitivity and specificity. If we were screening for a life-threatening illness like cancer, would you want to use a test that offers high sensitivity or high specificity? Well, obviously, in an ideal world, we would maximize both. But if you can't, then for screening tests, we want a higher sensitivity. A screening test needs a higher sensitivity in order to capture all of the true positives. But that needs to be balanced by a diagnostic test with high specificity so that the healthy individuals are not given false positive results. There's a trade-off between sensitivity and specificity, and it's very difficult to get both optimized in the same test. It would be most desirable to have a high sensitivity and high specificity for both the screening test and the diagnostic test. If you have to choose one over the other, though, you want high sensitivity for the screening test and high specificity for the diagnostic test. One last thing about sensitivity and specificity, look again at our 2x2 table. Sensitivity and specificity are both vertical calculations. Can you see that? That for sensitivity, you take the true positives and divide them by the true positives plus false negatives, which is the sum of that first column. And for the specificity, again, you do a vertical calculation. For specificity, though, you start at the bottom of the second column, put the true negatives in the numerator, and divide it by the total of true negatives and false positives, which is the sum of the second column. Okay, now look again at that table. What happens if we do those calculations horizontally? The horizontal calculations are the positive and negative predictive values. So let's talk about those now. Look at the first row of the table. Positive predictive value takes all of your true positives and divides them by everybody that tested positive. So what is that telling you? It's telling you the probability that a person who tests positive actually has the disease. The name kind of says it all. What is the predictive value of a positive test result? How well does a positive test result predict the presence of a disease? It's the proportion of all the positive test results that are true positives. So say a patient comes to your clinic and tests positive for mononucleosis, and then they ask you what the likelihood is that they actually have mononucleosis. What they're asking you is the positive predictive value of the particular test that you ran. Now, look at the second row. The negative predictive value is the true negatives divided by everyone that tested negative. So again, we're going horizontal on your diagram. True negatives divided by everybody that tested negative. What does that tell you? Again, it's telling you the probability that a person who tests negative is actually disease-free. Again, the name says it all, negative predictive value. So how well does a negative test result predict the absence of disease? It's the proportion of all the negative test results that are true negatives. So for positive and negative predictive values, you will be doing horizontal calculations in your 2x2 table. For positive predictive value, you would put the true positives in the numerator and put all of the positive test results in the denominator, the true positives plus the false positives. And likewise, for the negative predictive value, you would do a horizontal calculation with the negative test results. You would start at the bottom and put the true negatives in the numerator and then put all of the negative test results in the denominator. true negatives plus false negatives. So hopefully at this point this is all beginning to sink in. It really isn't difficult, and it can be very good to know this for test taking purposes. All right, let's get some practice doing these calculations. Take a look in your study guide and let's go through this question together. It asks you to calculate sensitivity, specificity, and positive and negative predictive value using the table that we've provided. You don't actually have to work the long division. Just pause the video and take a moment to set up the ratios, and then we'll go over the answers. Sensitivity is true positives divided by everybody with the disease. So here the number is 800 divided by 800 plus 100, or 800 over 900. Specificity is the true negatives divided by everybody who does not have the disease. So this is 1,400 divided by the sum of 200 plus 1,400, or 1,400 over 1,600. Again, sensitivity and specificity are going vertically, and then positive predictive value and negative predictive value are going horizontally. Positive predictive value is the true positives divided by all the people who tested positive, so it's 800 divided by 800 plus 200, or it's 800 over 1,000. And then negative predictive value is your true negatives, which is 1,400, divided by everyone who tested negative, which is 1,500. So this is pretty basic. I hope you're seeing that, but it's definitely high yield for your test. One last concept to cover on positive and negative predictive values is that the predictive values change as disease prevalence changes. So sensitivity and specificity are static. They don't change, but positive and negative predictive value, they do change according to disease prevalence. Positive predictive value increases with increasing disease prevalence. So in a low prevalence setting, even tests with high sensitivity and specificity result in low positive predictive values. This is one reason that you have to be really careful with screening tests in low prevalence situations. It might help you to look at this 2x2 table while we talk about this subject. So let's talk about a population with a high prevalence of a certain disease. If you have a lot of people with a particular disease, which values in the 2x2 table are going to change? You're going to be increasing number of people with disease compared with those that do not have disease. So the numbers in the first column will increase. If you increase the numbers in that first column, then what you see is an increase in your true positives and your false negatives. You're basically going to increase that whole vertical column when you have increasing prevalence of the disease, because the first column represents all the people who really do have the disease. So if you're increasing the true positives and the false negatives, what is that going to do to your positive predictive value? Looking at the equation, if you increase your true positives, it's going to increase the numerator. By increasing the numerator, you're going to increase the positive predictive value of the test. So high true positives and high prevalence equals a higher positive predictive value. Look at the equation for negative predictive value. We said with high prevalence, you are increasing your false negatives, which are in the denominator of the negative predictive value equation. By increasing your denominator, you are actually reducing the negative predictive value. When the disease is very prevalent in a population, a test with a given sensitivity and specificity will have a higher positive predictive value and a lower negative predictive value. It might help to think of it this way. When it's flu season and the prevalence of influenza is very high and somebody comes in with a high fever and body aches and all those flu symptoms, do you put more or less value on a positive flu test? Well, if that test is positive, you're going to believe it, right? And the positive predictive value is very high. What about a negative test? Well, if a patient comes in with symptoms of flu and are looking really ill, but they have a negative flu test, you're probably not going to believe that negative test, right? The negative predictive value is lower because the prevalence is so high. The reverse is true as well. If the prevalence is very low, the disease positive column decreases in value and your false positives and true negatives will increase. What happens when you're increasing your false positives and true negatives? How is this going to affect the equations? Well, in the equation for a positive predictive value, the increase in false positives will increase the value of the denominator. So decreasing disease prevalence will decrease positive predictive value. In the same way, decreasing prevalence increases the negative predictive value. So let's think about a real-world example where this comes into play. Do we screen every woman over the age of 50 for ovarian cancer by checking a CA-125 to screen? No, because the prevalence of the disease is low. With such a low disease prevalence, the positive predictive value of that test is going to be very, very low. Therefore, most of the people with a positive test are going to be negative for the disease, and they have to go through some invasive tests and experience a lot of stress while they wait to find out the results. But what if you just took the women over the age of 50 that were at high risk for ovarian cancer and then just screened them for CA125? There, the prevalence of the disease in that population is going to be a lot higher because you're narrowing the population to just those with a higher likelihood of the disease. And this will increase the positive predictive value of that test. You're not changing the test. It's just that how well a test predicts the presence or absence of disease is dependent on the prevalence of the disease in the population. Because of this, screening programs are more successful when they're targeting populations with higher prevalence of disease. All right, that's it for now. So let's go to your end of session quiz. Pause your video, answer those questions, and then turn back on your video so we can go through the answers together. All right, let's get started. What are the equations for sensitivity, specificity, positive predictive value, and negative predictive value? All right, one last time. Sensitivity is the true positives divided by the total of true positives plus false negatives. Specificity is the true negatives divided by the total sum of true negatives plus false positives. Positive predictive value is the true positives divided by the total sum of true positives plus false positives. And negative predictive value is the true negatives divided by the total sum of false negatives plus true negatives. So make sure you know those. We don't have rapid fire facts section in the study guide, but if we did, it would be those 4 equations, so know them. Next, what happens to positive predictive value of a diagnostic test when the disease prevalence increases? Remember that with increasing disease prevalence, you have increasing positive predictive value of a diagnostic test. And last one, a certain screening test has a 1% false negative rate. What's the sensitivity of this test? We didn't spend a lot of time on this, but we said that one of the equations for sensitivity is 1 minus the false negative rate, so the sensitivity of this test is 99%. And that's it for our lecture on diagnostic test evaluation. I'll see you next time.